What I've learned about patients with MPN is they've become very savvy about their diseases because of the sort of heterogeneity of the diseases and all that that brings to the table. So I'm grateful. I'm grateful to all of our colleagues that are here, both on the provider side and the industry side. We try to work together, obviously, to create new agents, to get them to market and figure out how to best utilize them. But really, I'm grateful to all of you and for the great work that Ann is doing on behalf of the patients. So thank you. And I'll try to make this quick. Tough to cover transplant in 30 minutes, but I'm gonna try to do it. As one transplanter once said to me about 2 decades ago, I love to transplant, but I hate to transplant. Why do we love to transplant? We love to transplant because it offers an opportunity for cure. We hate to transplant because it comes with a lot of baggage and risk. So I think it's fair to say if any of you have undergone transplant, or any of you are transplant colleagues in the audience today, or who might be listening, I think it's fair to say we would love to see transplant go away if at all heavenly possible, but it's not gone yet, and it still offers a chance for cure for a variety of individuals afflicted with myeloproliferative neoplasm. Now, most of you know that when we talk about transplant and MPN, we're largely talking about transplanting myelofibrosis. However, there are a variety of other transplant-eligible entities as well that fit into that MPN-like category. This is a slide that is a bit historical and is a bit outdated now. You can see it's a decade and a half old, but really shows some great trends, if you will. As you know, when we talk about transplant, we talk about 2 different types. We talk about auto-transplant, utilizing one's own stem cells, and allotransplant, which is the curative option for patients with myeloid malignancy primarily. And you can see the 2 curves over the course of time. Autotransplant still remains much more common, but for a variety of reasons, not something we utilize in patients with myeloproliferative neoplasm. When we talk about autotransplant, really what we're talking about is high-dose chemotherapy with stem cell rescue. Requires the collection of one's own stem cells and then reinfusion after high-dose chemotherapy. So it works for a variety of diseases, but for a variety of reasons, not effective in myeloproliferative neoplasm. However, allogeneic transplant is. But if you look at those historical curves, you can see there was a big dip in autotransplant, primarily because some of the studies demonstrated it wasn't effective for some illnesses, primarily in breast cancer. And you can see a slow, steady increase in allogeneic transplantation. Now, at the time that this slide was published in 2007 in the New England Journal of Medicine, only about 20 to 25,000 allogeneic transplants had been done. In the past 5 years alone, that trend has continued to go up exponentially, and in that 5-year interval, at least close to 60,000 transplants, allogeneic-wise, have been done. But importantly, why has transplant become so effective, and why does it continue to offer a cure? And we understand that at certain time points along the way. One is the prevention of graft versus host disease with certain molecules that are useful in suppressing the immune system and allowing the cells to potentially live harmoniously from another donor, an HLA matched donor, more on haplo in just a minute, to allow them to live effectively and harmoniously in your body with the potential to cure. But what we've also realized is there's an immune effect associated with transplant. When those cells are infused into the patient's body from the donor over the course of time, we can manipulate the graft by manipulating the immune system and allowing something we call graft versus disease, or graft versus leukemia, or graft versus myelofibrosis, depending on what the patient is being transplanted for. One of the other reasons down there on the bottom, right around 1995 or sometime just after that, 1997 or so, was what we call the advent of reduced intensity transplant. And it was because we recognized that the immune effect of transplant is so effective on the curative option for the patient, this opened the door to a far greater number of patients being eligible for transplantation, because what it allowed us to do is more safely administer this procedure to patients who were older or who had other comorbid conditions. As you all know, myeloproliferative neoplasm, especially those that tend to be advanced and transplant eligible, tend to afflict people at older ages. And so this has really changed who we transplant as it relates to myeloproliferative disease and all of the related entities. So the number continues to increase, but as I suggested already, God willing, someday will go away. A lot goes into the decision. Now, I love to sit, these are my favorite kind of programs. One of the things I love to do is sit and mingle. I won't have the opportunity to do that with all of you today, unfortunately, but I'll make sure that Ann provides my email to you, and we can certainly talk over the phone as well. Because when we talk about transplantation, a lot goes into it. Not just the disease, not just the availability of a donor, but everything that you bring to the table as a patient, your family, proximity to a center, very important. Is it feasible for you to live within, say, an hour of a transplant center for 30 days, for 90 days, for maybe more if there's complications? So access to transplant becomes very important. And what kind of support do you have? Now, thankfully, most of our patients have a good deal of support, but there are too many still that have maybe one provider who has to work. I see some heads nodding. That becomes very, very difficult. So when you make the decision to proceed with transplant, a lot goes into the decision between you and your transplant team. Another reason we hope transplant goes away, but for now it's here to stay for at least a little bit longer. In the pre-transplant setting, we talk about age. It tends to be one of the historical factors. Now, when I started doing transplant about 20 years ago as a fellow, 50 to 55 was sort of the maximum age limit. You will read now that there is no absolute cutoff based on age of patient. It really has more to do with how well you are physically otherwise. So in the pre-transplant setting, one of the goals is to maximize health so that we can maximize outcomes on the other side. But that's a huge advantage. Also, as we look at comorbid conditions and other things, we try to come up with risk scores that really help you to identify what is your risk associated with transplant. Frankly, what is the so-called TRM, or transplant-related mortality? What is the chance of dying from the procedure? Now, over the past 2 decades or so, that number has cut in half or even better. 20 years ago, I remember looking at statistics that were as high as 40% transplant-related mortality. That number's down dramatically to 10% or so for most types of transplant. But it can be highly variable. And so when you make the decision to go into transplant or not to go into transplant, that's one of the things you want to talk about, of course, with your provider. Importantly, and I'm sure my colleagues today have talked about this already, is risk stratification going into transplant, i.e., what is the risk associated with your disease? As the Y of transplant for myeloproliferative disease goes, the number one predictor is, and goal of transplant, even going to transplant or deciding to go to transplant, is it necessary? What is my life expectancy without a transplant versus with a transplant? And risk stratification models, in my opinion, have been one of the greatest breakthroughs for all of the cancers that we treat. Chronic versus blastic phase, is there need for cytoreduction? I.e., is the blast count very high? Has the disease started to morph? Do we need to do something more aggressively to lower the risk of the disease going into transplant, et cetera? And I talk a little bit here in this slide about treatment pre-transplant. And you might see up there cytoreduction and JAK inhibitors. One of the things that we're very excited about, and I'm going to talk a little bit about this as well, is what can we do with some of these newer agents to modify the disease course? Maybe shrink the spleen up. Maybe get the patient feeling better. Start to put muscle mass back on, weight, increase overall well-being as we talk about going into transplant so that we can lower that transplant-related morbidity and mortality. And then you can see down in the post-transplant, what can we do afterwards to help reduce the risk of relapse? What can we do without diminishing the graft, i.e. the donor cells? And we're going to talk a little bit more about that as well. So when we talk about transplant, to get to that center number, that really is reported to be somewhere between about 30 and 60%, the chance of cure, and we'll say here for the sake of argument, roughly 50%, depending on a variety of things. What can we do to maximize that number and minimize transplant-related morbidity and mortality? And of course, good donor selection is one of those things. Now, historically, and we're going to talk more about haplotransplant, about 70 to 80% of people have a donor identified for transplant because of the need for HLA matching. Nowadays, nearly everyone has a donor because of what we call haplotransplant, and we'll talk about that briefly as well. And then I mentioned the type of conditioning that's utilized. What is the conditioning? The conditioning does 2 things. It is the chemotherapy we give prior to the infusion of the donor cells in an effort to both control the disease, to create a physiologic and so-called anatomic space for the new donor cells to engraft in the body. The donor cells will hone their way into the bone marrow and over time start to lead to what we call engraftment. and eventually immune reconstitution. And as I suggested, that immune reconstitution, as the donor cells grow in your body, is one of the things that helps to keep the disease at bay. So the conditioning, reduced intensity versus myeloablative, is another important factor that is determined by age, by donor source, and by disease status at the time of transplantation. And God forbid we face the unfortunate reality of transplant, which as a transplant physician I will stand here and tell you is still far too high. If we look at a pie for these disease states, maybe we're talking a 40-50% cure rate and maybe a 10 to 20% chance of something serious happening from the transplant itself. Well, what's the rest of the pie? The rest of the pie, unfortunately, consists of relapse of the disease. The good news is there's things we're starting to do, as I suggested, like utilizing post-transplant maintenance strategies, but other ways to manipulate the donor cells if we start to recognize that the disease is coming back prematurely. And depending on when that happens, there are certain things we can do therapeutically. One of the ways we realized that immune effect on the disease was so important, after we realized that, we started to utilize something called donor lymphocyte infusion. So if your physician talks to you about that as a means to prevent or to treat an early relapse, that simply means we're collecting donor lymphocyte cells and reinfusing them into your body to induce an immune effect against the disease, and trying to do that without as much graft versus host disease as possible. And of course, we start to talk about second transplant, et cetera. And very importantly, I think the summative of all of this is clinical trial. And that's why I think what Ann and what all of you are doing here today, and what has led to such great breakthroughs, is accessibility to clinical trials, which reduce the risk as well. Now, there's a lot of words on this slide. I'm not going to read through it entirely. But before we talk more about myelofibrosis in particular, I mentioned that there are other entities in the myeloproliferative neoplasm spectrum that we do transplant routinely. The reason I share this slide is to drive home the need for accurate diagnosis. Every slide here today is here for a reason. Unfortunately, some of them contain a whole lot of data. But I think it's important, especially as we're here with an advocacy group, to recognize that these diseases can mimic other entities that have very different prognosis associated with them. In Pittsburgh, I had the good fortune of working with Dr. Steve Swerdlow, who is a world-renowned, now just retired hematopathologist. I think it's important, you all owe it to yourselves if you're diagnosed with one of these conditions, to have somebody that is dedicated to hematopathology to review your bone marrow test or your blood work, et cetera, to help make sure you have as accurate a diagnosis as you possibly can, because even the diagnostic criteria for these entities is rapidly evolving. And so you can see here, pick any one of these lines, there's very striking similarities between some of these entities, but what we know is that the survival for these different entities is strongly different, and that leads to the potential need or lack thereof for something as serious as committing to a bone marrow, i.e. stem cell transplant. And by the way, if I say those two things, bone marrow versus stem cell, they're synonymous nowadays. In the old days, we used to do the harvesting from the bone marrow itself, which we talked a little bit about in that talk where we first met. We now collect the stem cells from the peripheral blood. So it's a much safer thing for the donor in that they do not have to go under general anesthesia and feel like they got kicked with a Clydesdale from operators going in to take the bone marrow out. But rather, we give shots of Neupogen, a stem cell stimulant, if you will, white cell stimulant, and collect the donor cells that way. So they're synonymous terms. But what it means for you as a recipient of stem cell therapy done from the peripheral blood is a larger cell dose, which means more rapid engraftment. So again, I share this slide to show that there's such striking similarity and to encourage you to advocate for yourself in terms of making sure your diagnosis is as clear as it possibly can be as you decide on treatment strategies. And as I suggested, this is just one example. We're seeing an increased number of a very rare disease now called atypical CML. CML, as many of you might know, is defined by a certain chromosomal abnormality, but some patients have a bone marrow that looks very much like CML, but otherwise doesn't have the chromosomal pattern associated with it, and sometimes get mislabeled. The new diagnostic criteria are pretty strict for diagnosing this condition, and I share the outcomes when compared to other MPN-like entities, you can see this particular entity tends to do worse, and this is an entity that we would want to get somebody to transplant typically as soon as we can. So again, accuracy in diagnosis, I think, is crucial, especially when embarking upon something as intense as transplantation. And that is, again, kind of emphasized in this slide and then here as well. Now, why do I show this slide? I'm always reluctant to show survival curves to patient groups, but again, you all are very savvy people. The reason I show this slide is to point out just how few of these patients have been studied with certain entities. What does that mean for us as colleagues as I look around the room? We need to collaborate. We need to work together. We need to share our information. And again, I think venues like this allow us to come together and do that. National meetings, regional meetings, et cetera. Because it's very hard to assess the risk associated with, any given patient if I've only transplanted 3 or 4 patients with that entity. It's not a fair assessment to you. We have to share our information, and I think that's crucial as we help to develop new strategies. The same can be said here. Some of these numbers very small, population sizes of only maybe 9 patients. That's not enough for us to make life-changing decisions for you and your care. So as I suggested, risk stratification is the most important thing. When somebody gets referred to me for transplant consideration, I want to make sure that not only I've got the right diagnosis, but I want to make sure that I'm risk stratifying your disease appropriately so that I can help you decide whether or not we should look at transplant. And importantly, the timing of transplant. The Achilles heel of transplant, and myelofibrosis in particular, is one of timing. When is the time to pull the trigger and go for it? When is the time to take the next step? It's not always an easy answer. There are some guidelines that we follow, but it's highly variable for everybody. If I'm following a patient and I'm noticing that their clinical condition is declining despite maybe stability of the counts, I might need to take that chance a little bit earlier, or maybe do something different to help improve their status going into the transplant, as I alluded to earlier. And so I share some of the risk stratification models. You're all familiar with DIPS scores, DIPS plus scores, MIP70, MIP70 plus. When we talk about myelofibrosis, whether it be primary or secondary, we tend to utilize these strategies to help determine who should go to transplant. And one of the nice things is we've developed these new models, and these continue to be adapted. Even within some of the low, intermediate, and high-risk categories, we're starting to see new ways of shifting those curves even more. But we want to be accurate so we can say to you, this is the likelihood of you doing well with transplant, and what your outcomes are likely to be without transplant, so that you can make a well-informed decision as much as possible. Now, historically, with some of these risk models, that 5-year overall survival was very, very close one to the other. And what we learned also is that some of the older models, we might be off anywhere from 10 to 25% of the time. Now, if you come to me and I say your high risk is a life expectancy of 2 years, and so it's good, maybe it's time to go forward with transplant, but I'm wrong 25% of the time, that's a huge problem. And so risk stratification models remain our best friends as we work together in determining the timing of transplantation. Now, patient selection for transplant, again, is based on risk stratification modeling, but again, I talked about the need to collaborate, to work together, and this is a good example of that. The EBMT, the European group, came up with these guidelines for transplanting primary myelofibrosis primarily, and I will tell you that a lot of this is applied to secondary, those who have maybe evolved from P-Vera or from ET, et cetera. Similar risk stratification models go into that, a little bit more nuanced, but nevertheless, it is recommended that patients with higher risk disease move to transplant earlier, or at the very least be referred to a transplant center and start the donor identification process so all of that is in a row when the time of transplant is necessary. And I would argue, too, that clinical trial perhaps should take precedence over even immediate transplant in some patients, not everyone, but again, something, if you have availability for, something to consider. Now, what about the lower risk patients, intermediate 1? Well, if the age is kind of on that tipping scale, if we're getting to the point where the risk of transplantation is starting to go up because of age, maybe we're going to look at other things. Are we refractory for transfusion support? We know that's a very high-risk feature regardless of risk stratification modeling. If you're needing a lot of transfusions, that is an independent predictor of potentially poor outcomes, especially if they're not being effectively managed with whatever therapy is being utilized. Are we seeing peripheral blood blasts? And is that blast count starting to go up, perhaps suggesting that the amount of fibrosis in the bone marrow is changing as well? And then are there adverse chromosomal patterns or adverse molecular findings? And again, that's been one of the great advantages of modern medicine, is the ability to now look deeper than 20 cells or 300 cells or 500 cells, to look at tens of thousands or even hundreds of thousands of cells, to look deep within the DNA and find certain mutations that we know change outcomes. Of course, the identification of JAK2 mutations, et cetera, is key in terms of diagnostic and prognostic findings, but other abnormalities have been identified as well that are very important to us as transplanters when we make a decision as to whether or not to go forward with transplantation. So what we're doing over time now, as the MIPS suggested, is incorporating into your risk stratification models not only cytogenetics, not only your age, not only all the things that have been historically a part of that, but now molecular mutations as well. And I would argue, too, that clonal evolution, the identification of new mutations over time, is a risk factor that we need to take into consideration also. As I mentioned, the choice for a conditioning regimen. And what this slide shows is that there are a host available to you. When I send patients out, I have a few patients that come to me for a transplant consideration, but they're from Florida or they're from the West Coast. And they're coming just to get an opinion, and then they go to another center and the conditioning regimen is maybe slightly different. Which of these regimens tends to be institutional standards? What's more important is that all of these are acceptable, but what type of transplant you're embarking upon, i.e. is it myeloablative, meaning are we trying to eradicate the disease with the conditioning regimen? Is it reduced intensity, meaning we're doing a little bit of that, but really relying on the donor cells to immunologically kill the disease? Or is it what we call non-ablative, meaning we're simply trying to suppress the immune system and allow the donor cells to root and over time treat the disease? And you can see as you go up the ladder there, if you will, the staircase, the non-ablative, reduced intensity, myeloablative, you unfortunately increase the risk of protocol toxicity, but might increase the risk, increase the chances of cure as the intensity increases. So those are things you have to balance. And again, as you go into that, it has a lot to do with not only your age, but your disease status, how well controlled is the disease, and what are comorbid illnesses. Do you have bad diabetes? Do you have heart disease? Do you have heart disease that maybe, these are just some scenarios that I oftentimes think about. Do you have heart disease that maybe you're on antiplatelet therapy, and I can't afford to have you off of that very long, so maybe I want to give you something less intense so I don't kill off all your platelets for a very long period of time. A lot goes into it and things that you have to consider with your transplant team. And I mentioned to you that, thank God, today, we have the overwhelming majority of patients who need a transplant identifying a donor suitable for their transplant because of the advent of something we call haplotransplant. This basically means that you don't have to be perfectly matched anymore. You can be mismatched at any number of HLA loci because of the advent of something called post-transplant cyclophosphamide or post-transplant cytoxin, which essentially neutralizes, if you will, the allo T cells, the alloreactive T cells. Those are the cells that are going into you from the donor. And imagine if they're mismatched and we do nothing about that, those cells are going to attack not only your disease, but they're going to attack your body with severe graft versus host disease. Because of this new mechanism, this treatment now that is approaching 20 years old in theory and is now a standard part of clinical practice, nearly everyone finds a donor for transplant if a transplant is needed. And again, we hope we're getting away from that, but for now, transplant is still a curative option for many individuals. Other considerations that we have to think about, and again, there are many. I share this as a summative slide to go back to the second slide I shared at the beginning. There's a lot that goes into this decision. How much time do you want to be in the hospital? What's the likelihood of being cured? How much time am I going to be away from my family? Do I want to do it around the holidays? Do I have time to wait to do it after the holidays? Do I have a wedding of one of my children? There's a lot that goes into it. Don't be afraid to share those things with your transplant team. They're essential, because the answer may be yes, we can wait. Or the answer can be no. I had a lady I transplanted many years ago. Her single goal was to dance at her son's wedding, but the disease was moving relatively quickly, and we had to act and take the chance that she would be at the wedding because she was unlikely to be at the wedding. And I wish I had the picture to share you of her dancing with her son at the wedding. It was really heartwarming. But a lot goes into it. And as I suggested earlier, when you make those decisions, share everything. And as a transplant physician, when we see transplant go away, we'll celebrate together. In the meantime, we're going to do everything we can, of course, to work together, especially with our colleagues and all the new agents that have become available. What can we do in the pre- and post-transplant setting? For me, that's a particular area of interest. As a transplant physician who treats MPN, how can we maximize disease status going in and reduce the risk of relapse coming out, perhaps by utilizing some of these new agents that might be working at the stem cell level, that might actually affect the malignant clone that's causing the disease itself? And what can we do? And a lot of research is needed in that area. It's an exciting area for sure. I'm going to close with a tribute to E. Don Thomas. Don Thomas was sort of the father of transplant. I believe it was last month. He had died just a decade ago last month. In 1990, he received the Nobel Prize for Physiology and Medicine. He's pictured here with his wife, Dorothy, who worked in his lab. They worked together. Since the time Don Thomas sort of invented transplant and understood the allo effect, the immune effect associated with this, hundreds of thousands of transplants have been done. Countless lives have been saved. But Don Thomas would tell you himself, and unfortunately when he passed away, the transplant-related morbidity and mortality was too high. It's still too high, but it's getting better. And I think it's his work and the work of all of his successors that has allowed us to continue to see that number come down, that transplant-related mortality go down, and that cure rate go up. Because the number I quoted earlier of 50% as of today was at least half of that when Don Thomas died. So good things are happening. He's had countless numbers of pictures with the countless number of patients' lives that he affected, and we certainly owe him a lot as transplanters. So again, Ann, you're kind of paving the way like he did. God bless you and your work. Thank you.